Medicine. He also served when he was in government as Associate Director of the National Institutes of Health. It's an unqualified title. Did you hear that? Associate Director of the National Institutes of Health, where he led the Behavioral and Social Sciences programs. He's Distinguished Emeritus Professor of Health Services and Medicine at UCLA, where he led the UCLA-RAN AHRQ Health Services Training Program and the UCLA-RAN CDC Prevention Research Center. He was chair of the Department of Health Services and is a past president of the American Psychological Association Division of Health Psychology. And I was going to read the list of other things he was past president of, but it's too long. He's former editor-in-chief, and I can say these two because he was only editor-in-chief of a few things. Editor-in-chief of Health Psychology and Annals of Behavioral Medicine, highly relevant. His 20 books and over 530 articles or chapters have been cited more than 32,000 times. For those of you who keep score, that's an H-index of more than 93. And the ISI includes him in the listing of the most cited authors in his field, which is defined as above the 99.5th percentile. Professor Kaplan is an elected member of the National Academy of Medicine. And he's going to talk to us. He said, I think he told me he was going to be provocative, and I don't know if I imagined this, that he was going to disagree with me or have a different view, at least, which I really appreciate. And he's going to talk about overvalued cures, a new narrative for achieving a healthy society. Professor Kaplan.
Thank you. I appreciate that. Well, Richard, thank you for such a kind introduction. It's great to see so many friends from BU and others. It's just great to be here. So I'm going to talk to you a little bit about this notion of overvalued cures. And it's related to the introduction because before I went to AHRQ, I was one of the associate directors in the Office of the Director at the NIH. And I had come from academia, very much unprepared for this job, actually. And you met Francis Collins and agreed to do it on a 2-year IPA, and then was there 4 years actually, and stayed in government a little bit longer than that. But it was a very interesting experience at first because I was a professor, very much like all of you folks, and that I was just kind of used to the professor life. And when I got to NIH, the first thing that I noticed was that my calendar was full all the time, and I just didn't have any control over it. And people would schedule meetings with me, and it would often be in the first part of my tour of service there, there'd be people like, from the American Association of X, and the American Association of Pharmacology, the American Association of Cell Biology, the American Association or whatever, and they'd come to see me. And by the way, the first part of the visits were always pretty good. So they come in and they kind of butter you up and say, oh, Dr. Kaplan, I read your article, and so forth. And then there's a phase 2, and in the phase 2, I was told that whatever they did, the American Association of whatever, was doing an incredibly good job. And they said that they needed more money for biomedical research if they were from a research organization, or they said that they needed more money for clinical care if they were from a clinical organization. And the message was always, everything is just really good with what we do, and what we need is we need more money, and then after that we need more money. And in fact, they said that they needed more money to keep doing exactly what they were already doing. That they were doing great mechanistic science, they were doing great at advanced disease detection, and that they thought that advanced medical therapy, or aggressive medical therapy, was doing a great job. And so I'd like to sort of get into, well, how well are we really doing? And as we sort of try to conceptualize where we're going with a new field like community health sciences, I'd like to ask a couple questions. And one is, how does the community health science perspective differ from more traditional clinical research? And I'm going to, in contrast to some of the earlier presentations, say this talk is going to be a little bit more clinically slanted. And then how are we doing on the use of surrogate markers, which we've been hearing a lot about because it fits with the mechanistic model? And then are we overlooking important opportunities to improve population health because that we're so focused on wanting to do just what we've been doing over the course of the last long time? So some of this relates to what the Patient-Centered Outcomes Research Institute, or PCORI, does. And that what makes PCORI differ from other clinical research orientations is that it's patient-centered. and you might think of this as community-centered. So there are a range of comparative effectiveness questions that PCORI tries to answer, and a lot of what they do is clinical, but their charter is much broader than that. Actually, their charter goes to population health. So on the clinical side, a lot of what they do is, does treatment A work better than treatment B? Just clinical trials. And so, they might look at vitamin A antagonists like warfarin, and they might look at those in comparison to these very expensive alternatives. So for people who might be getting a joint replaced, for example, they might ask, do the newer, more expensive drugs reduce the probability of deep vein thrombosis or pulmonary embolism? But then there are these other questions which actually are in their charter as well. So how do we use limited resources to maximize population health? And that those resources might be invested across a wide range of opportunities, some of which are medical and some of which are community-based. And then they might look at these sort of clinically related questions, for example. So in stroke care, there's a huge emphasis now on getting the person, if they're a candidate for TPA, get them to their TPA really fast. And the question is, how well is that working? Or would it be better to use those resources to support community-wide approaches to stroke prevention through perhaps community-based blood pressure control? And what about costs? Well, when PCORI was founded, interestingly, the one thing they can't talk about is cost, or in particular, cost per quality adjusted life year. So I want to get into the cost issue today, because that cost spent on medical care, or money spent on medical care, can be used for community-based participatory activities. And some of your colleagues here in Boston have sort of taken this law to task. So Milt Weinstein and Peter Newman wrote this piece in the New England Journal a couple years ago just saying, how did they ever come to this conclusion that you can't consider cost? But in fact, NIH and AHRQ are very hesitant to get into the discussion of cost, even though cost is extremely important. And to sort of introduce that to you, you might think of this example. So think about a family of 4. So here's a picture of a young family of 4. Well, what do you think the median income is for a family of 4 in the United States? Any ballpark estimates? Well, it's about $50,000 per year. So, by the way, this idea comes from my colleague Kevin Schulman, who's at Duke. But he says it's a little bit higher, but I looked it up, and it came up with 50. And if it's just an individual, it's about $37,000 per year. So in this family of 4, perhaps both members of the couple are not working, and so if they're depending on one income, it's going to be at $37,900. Well, how much money is spent on the average family for health care in the United States? Yes? Turns out it's about $25,000 per year. Not all of this actually comes out of paycheck, but if you look at, for people employed in medium-sized organizations, it's about $11,000 per year comes out of this $50,000 to pay for health care for this family of 4, and overall about $25,000 is spent on them. And that money is spent for medical services. If we could get a better handle on that, it could be used for all kinds of things. But in particular, we could do more with community-based health services if we had the right evidence for that. Now I'm going to take a detour for a couple minutes. So this is sort of an odd detour, but hopefully it will make sense, because I want to talk about the narrative that is behind our huge investments in a particular brand of biomedical research and a particular type of investment in making populations healthier. So before I do that, does anybody know who this person is, Vannevar Bush? Sandra does. So, I've done this a couple times now. I've gone to audiences. So Vannevar Bush actually was a native Bostonian. Very few people have any idea who this guy was. But it turns out, I think he was one of the most influential thinkers in the 20th century. And here's why. So he started Raytheon. He built an early analog computer. And in the 1930s, he developed a concept that actually was able to search enormous documents for words, very much like Google does now. So think of it as an early Google, but developed almost 100 years ago. So the guy was an incredible thinker. But what he's most famous for is that in 1940, he advised President Roosevelt on cooperation between science and the military. And this became known as the military-industrial complex and scientific-industrial complex. He persuaded Roosevelt to build the bomb, and then he persuaded Truman to drop the bomb. And so he headed the Manhattan Project, and in fact, this was all based on this idea that engineering science, he was an engineer, engineering science is hugely important and will do good things, or in this case, very bad things. Then after the war, in the late 1940s, he created the blueprint for research in US universities. And what happened was he went to President Truman and he said, the huge success in World War II, and that we had applied engineering sciences to build the bomb, but do a lot of other stuff. The United States had not been thought of as an intellectual leader at the time. And so as a function of this collaboration between engineers and scientists and so forth, that the United States became respected as a scientific and engineering powerhouse. And so Bush's idea was that what we should do is we should give big grants to universities. So before about 1950 or into the 50s and 60s, there weren't these big research-intensive universities like they are now. And in fact, universities had a very different structure. And Bush had the very deliberate idea that the way we're going to do this is we're going to turn some of these universities into intensive, research-intensive science engines, and we're going to do it by buying off the administrations of the universities with big overhead on grants. And so before that, and by the way, he looked at the European structure. So the French, for example, had national laboratories. And he said, that will never work. And he said, make it independent, make scientists compete, and so forth. So as part of this, that is this continuing effort for science, he wrote a report that was called Science, the Endless Frontier. And he created this narrative, and the narrative was that contemporary science is going to solve the most perplexing problems of society. And the way we're going to do this is we're going to put massive amounts of money into universities. And the universities will buy into it. And by the way, he said, and we'll subsidize other sciences because that it will pay for libraries and a lot of other facilities. But he had very particular ideas about what science should be. And so, for example, he said science should be divided into basic and applied, and we should put almost all the money into basic. And that it should be based on, because he was an engineer, it should be based on identifying mechanisms. And that applied research, particularly behavioral and social sciences research, should be maybe tolerated, but certainly not promoted. In fact, he went down, at one point he was a vice president of MIT, and then he moved to Washington, and he was the president of the Carnegie Institute there. And the first thing he did is he got rid of the anthropology department. And in fact, in his writings, he said things like, social scientists write these books and then people put them on the shelves and it's a waste of everybody's time and they just collect dust and so forth. So he wasn't a big fan. And in fact, the argument that I want to make is that this narrative has persisted and continues to have a big impact on the way we fund things and the way we think about things. And the narrative for medicine has been very mechanistic. And this is something I really picked up in my years at the NIH. So it's always, whatever the question was, it's what is the mechanism? So the idea is that the way we do biomedical research and practice is first we identify the basic mechanisms through preclinical research. Then in clinics we find problems, that is we use advanced diagnostics. And then in the clinic we use evidence-based interventions to fix the problems. And so the basic structure is you find the problem and then you fix it. And in fact, this is replicated, I think, in the way that we market medicine and healthcare to the public. And so I gave a grand rounds in Toronto recently, and interestingly, I was in my hotel room in the morning getting ready to go give my talk, and they gave me a copy of the Toronto Globe and Mail. And the University of Toronto actually had this ad just behind the front page of the paper, and it said, "Cancer switched off here." And the idea is that, if you have cancer, you just go to the University of Toronto and they'll find the gene and they'll switch it off and you'll be fine. So the question I want to ask today is this narrative right? How well are we really doing with this narrative in the model? And how well is the narrative supported by contemporary data? So let me just begin by one detour. I spent 3 years on this committee for the National Academies, where we ended up making this recommendation. We said the Secretary of the Department of Health and Human Services should set a national goal on life expectancy and per capita expenditure that in about a generation from now, about 2030, it will bring the U.S. to average among wealthy economies in life expectancy and in expenditures. And the evidence for this, of course, in public health schools, everybody is drowned in this figure or related ones. But as you can see on the x-axis, we're way out on the extreme in terms of expenditure, but actually below average in terms of life expectancy. And when I was at the NIH, I helped support another academy study, a committee chaired by Steve Wolf, where we looked at U.S. health outcomes in relation to 16 peer countries. So 17 countries altogether. Most of them were in North America, but they also, and Europe, Western Europe. They also included Australia and Japan and Canada. And the question was, well, if we're really so good, I mean, if everything's so great, we're doing so well, how do we stack up against these economic competitors? And of course, in schools of public health, you know this already, but I'll just breeze through this to show that actually, as recently as 1980, we were right about in the center of the distribution. And then since 1980, we've gone to the very bottom among these rich countries for both men and women. And if you look at the indicator, the probability of surviving to your 50th birthday, and the way I like to think about this is, it's your 50th birthday, they're gonna bring out a big cake, and the question is, are you there alive to blow the candles out? Well, it's not just that we're last for men and women, but we're last for a considerable margin. And so over the course of time, we were toward the bottom in 1980. And so for men, we've gotten to the bottom, and women on the right side, we've completely gone off the scale. So for Richard, I told him yesterday, I said, you know, I'm going to give you my opinions about what I think community health science ought to be thinking about. This is opinion, you know, it could be completely wrong, but this is just for the discussion, because he told me I could try to provoke topics for discussion. So one of the arguments I'd like to make is that in community health sciences, maybe we shouldn't care that much about mechanism. So on the right side here, this is what you always see in drug development. You find targets, and so there might be molecular targets, and you develop the drug, you test the drug in animals, you do it in human studies, and ultimately it cures the disease. So part of the argument is that, in fact, this model hasn't really produced the results that we want very often. Just as an example, when I was at NIH, I served on a little committee that was looking at the replicability problem. But one of the big surprises to me was that if you look at studies like cell biology, and you ask, if you're studying a cell line, I mean, the typical thing is you're a cell biologist, you buy a cell line, you study this cell line. Well, it turns out that, in fact, it's pretty common for the cell line that you're studying not to be the cell line you thought it was. So for example, you might buy guinea pig cells, and it turns out that it's been contaminated and they're really mouse cells. Or you think you're studying ovarian cells, and they're actually breast cells. And it's not uncommon. This occurs in somewhere between 14 and 30% of all cell lines. Such a big problem now, by the way, that if you buy cell lines, you're supposed to go out and purchase this service. And the service will tell you whether or not what you're studying is really what you think it is. If you look at animal studies, so the basic model at the NIH is that you start with mouse models. And there was Mike Lauer did this review where the computer reads all the NIH grants. And so 70% of NIH grants talk about mouse models. So mouse models are very core to what the NIH does. And it's a huge part of what's spent, because at least 50% is spent on basic stuff. And so the question here is, well, if you do mouse studies, how well do those mouse studies replicate? So there's an ALS group that takes published studies on therapeutics in mouse models and just replicates them. So the black bars are, the blue bars, or the teal-colored bars, are studies of various molecules that were tested in mouse models. And you can see that all of these published studies show that these molecules or compounds work really well. But when this group goes out and tries to exactly replicate those studies, the black bars, they never did it. They never replicated any of them, and many of them went in the opposite direction. Another issue is generalizability. And so in developing a science of community health science, one of the arguments that I think we should consider is we should never assume generalizability because it's all about context. And we keep hearing that. And I love this quote from Norbert Wiener. He says, "The best model for a cat is another cat, or preferably the same cat." Now, why would he say that? Well, it turns out that generalization across species is actually pretty rare. So when you dig into this literature, first of all, sometimes things don't replicate from different strains of mice, but the generalizability from mice to rats often doesn't carry. So if it doesn't generalize within rodents, can we really expect it to generalize from mice to humans? And in fact, I was at a meeting with Robin Barr, a great guy who's the director of extramural research at the National Institutes of Aging, and he made this interesting comment. He said, "We've cured Alzheimer's disease 300 times in mouse models, but so far failed to cure it in any humans." And he was referring to this meta-analysis from Cummings and his colleagues that looked at placebo-controlled trials in Alzheimer's disease using the same compounds or molecules that have been used in mouse studies. And they had 221 consecutive null trials. So another part of community health sciences, I think, should emphasize what I call patient-centered outcomes. Ira Wilson here wrote this famous paper with Paul Cleary years ago about, everything is directed toward these types of outcomes. And it's sort of combinations of quality of life and life expectancy. And one of the arguments is, by the way, the publications in this area have been going up, but this is catching on perhaps more so in clinical medicine than it is in other areas. So Stanford ran rounds last week, and most weeks they say the purpose of healthcare is to increase the length of life and to improve quality of life, and that other measures are only important if we can show their relevance through their connection to these two important outcomes. And it raises a question, maybe for community health sciences, certainly for outcomes research, is, well, what should the outcome be if it's life expectancy? Should it be deaths from cancer, or should it be deaths from all causes? Or another way to ask the question is being dead from cancer worse than being dead from something else? And my argument is that in community health sciences, we should look at this combination of life expectancy and quality of life. And life expectancy is not disease specific, it's life expectancy. So for example, some years ago I had the opportunity to reanalyze data from the Physicians' Health Study, a study where physician subjects were randomly assigned to aspirin or to placebo, and they were followed over the course of time. And what happened in the early phases, this is part of the early stop for the trial because the outcome was deaths from myocardial infarctions, and there were significantly fewer of them in the aspirin group. And so this is a very positive trial, a lot of enthusiasm for aspirin. But actually, if you look at just cardiovascular deaths, in fact, exactly the same number of physicians died within the follow-up period. And these are just cardiovascular deaths. So there was actually no change in how long these people lived. They all died within the study period, and they all died prematurely. So this sort of gets at this notion of, no, we have to look not at disease-specific mortality, but at all cause. So I'd like to sort of launch into this discussion now of well, what are we doing? How have we been misled to look at other things? And so one of the arguments is that in community health sciences, I think that we should downplay what clinicians often prefer to measure. And what do they prefer to measure? They prefer to measure what I might call surrogate markers. So blood pressure, weight, glycosylated hemoglobin, LDL cholesterol. But they want to avoid self-report. And in fact, this is true in public health sciences as well. People say, well, who believes in self-report? So the argument is that information is meaningful if it comes from your veins, and certainly not from your mouth. And so I won't go into what a surrogate endpoint is, but I'd just like to sort of get at this question. How well is all this really working? And if we sort of use surrogate markers versus real endpoints. So one of the points I want to emphasize is it's actually pretty rare that a new compound or molecule works. And so this is the therapeutic pipeline. I know you've seen it before, but I think it's worth reemphasizing that for each 10,000 compounds that might be patented, that only about 250 of them make it into preclinical studies. Only about 5 of them make it into clinical trials. And only 1 of the 10,000 actually becomes a licensed product. So it's a rare, rare survival that actually becomes a product. And one of the questions is, how do they become a product? Do they become a product that's licensed because that they do a really great job on quality of life and life expectancy, or do they get licensed on the basis of surrogate markers? And one of the arguments is that if we focus on surrogate markers, the idea is it's just like Vinegar Bush's machines, that if you have a malfunctioning part in your car, you can fix that part, but if you don't fix it, the car will fall apart. And the assumption is the same with something like blood pressure or cholesterol, that if we change that, then we assume almost for certain it changes what we're interested in. So can we make important clinical and policy decisions based on surrogates? And mechanistic model says yes, but actually let's look at some of the data for this. So for example, lifestyle interventions on the incidence of progression to diabetes. This is like the DPP, the Diabetes Prevention Program. Actually, the DPP in this meta-analysis, I don't have a pointer, there it is here, but it's actually the same result in lots of them. It really does work. So if you intervene, you can reduce the probability of transition to diabetes. But the question is, and so this problem is fixed, but in fact, when we look at outcomes for cardiovascular mortality or all-cause mortality, it doesn't make much difference. One of the big stories in medicine is that if you have coronary artery disease and you have stenosis of your coronary arteries, you can put a stent in there, and that's fixed. But in fact, there have been big randomized trials, and multiple, where people are randomly assigned to these are people without acute coronary syndrome, but they're randomly assigned to PCI or to medical management and followed. And in fact, if you look at the lower right, which is all-cause mortality, it doesn't make much difference. This is the Accord trial. People randomly assigned to aggressive therapy, intensive therapy for their type 2 diabetes or to standard care. So we create a difference between them. So it looks like this problem's fixed. Lower glycosylated hemoglobin, of course, is more desirable. So this problem is better. But in fact, when we look at all-cause mortality on the right side, actually there was a significant increase rather than decrease in all-cause mortality. I have so many of these, and I'm running out of time. But suffice it to say, well, this is a sort of a famous trial for people who have anemia because they have renal disease or cancers, randomly assigned to erythropoietin-stimulating agents to bring their hemoglobin up. And you can see group 1 that it worked. So they fixed this problem. But actually, if you look at who ends up on dialysis, they're more likely to end up on dialysis rather than less likely if they had this intervention. I'm going to run out of time. So whenever I give these talks, I go to the New England Journal from that week, and there's an example. And so this is a weight one where you can in the look ahead trial actually can produce weight loss, but outcomes on the right side, no effect. So I won't bore you with all these, but I have literally hundreds of these now, and it's the same story. This is sort of a more recent one, which is the PCSK9 inhibitors. It's an important story because PCSK9 inhibitors are ungodly expensive. So it's going to be about $14,000 per patient per year, and it was supposed to be for people who had familiar hypercholesterolemias, but actually the pharmaceutical company that makes these are pushing hard to get wider distribution. And there was a trial that came out a couple months ago that was published in the New England Journal where people took placebo plus statins or PCSK9 inhibitors, and they created this big difference between this. Now, the top line is LDL cholesterols of 90, so these people are doing great. PCSK9 inhibitors will get them to 30. I don't know what the right number is, by the way. So if you have high systolic blood pressure, the right number is not 0. You don't want to get to 0. But the idea is to push people down as close to 0 as possible to fix this problem. But it's the same story when you look at all-cause mortality. All the differences are small. It actually is higher rather than lower in the PCSK9 group. So I'm running out of time. I'd like to just take the couple minutes left to talk about the bigger implications of this and try to link it back to where we're going with community health sciences. So how about our family of four? Well, what's going to happen if PCSK9 inhibitors get 20% of the market? And Kevin Schulman published this result recently. It turns out that this family of four is going to be paying about $500 a month in their health insurance premium to cover the other people who are going to be taking PCSK9 inhibitors with no clear evidence it's going to help them. So I just want to mention that how often do clinical trials produce null results like I've been showing you? Well, a couple years ago, we had the opportunity to look at every NHLBI trial that was funded over the last 50 years. And since I was working at NIH at the time, I had access to this. The interesting finding was that prior to 2000, about almost 60% of NHLBI trials produced a positive result. After 2000, on the right side of this, almost none of them did. And in fact, portrayed another way, the left side are the before 2000 trials, and the black boxes are positive trials. And then the right side is after 2000, where we went from almost all, well, 60% to about 8%. And for all-cause mortality, none of the trials showed a benefit, except the SPRINT trial, which was published after we did this, actually was the first NHLBI trial in 20 years that showed a benefit for all-cause mortality. So, what should community health sciences not be doing? So, as you define it. And one of the arguments I wanted to make is that community health sciences should not be in the business, in my opinion, of being marketers for cancer screening or other things. And this is when I sort of first got involved with this. Actually, people would come to us and they'd say, you're in a school of public health, you can help us increase the compliance rate with mammography. And in fact, there were these messages. So here's a woman who's in, say, her mid-60s, and she's talking to her doctor about whether or not she should get a mammogram. And what she's thinking is, well, if I get a mammogram, I can feel safe that I'm not going to die of breast cancer. And here's her doctor. And what her doctor might be thinking, because he's an evidence-based guy and he knows the literature, is he's thinking, I'm only going to increase her risk of survival from about 0.5% or 0.5% to about 0.4%, because he knows the literature. But if I do it for every woman that I see over the course of a couple years, I might save a life. And so I think that if community health sciences is going to get into this business of promoting things, they have to promote it in the respect that they're going to help people understand things as their providers already do. So a couple things in closing, and it's going to take me 5 or 6 minutes to close, if that's okay, because I always bring more than I can talk about. I just want to talk about this notion of drug approvals based on surrogate markers. And this comes from an analysis done by Zuckerman. It's actually not this Zuckerman, but it's surprisingly close. This is Diana Zuckerman, who's spent a lot of time and has been a big opponent of the way drugs are approved, but also has been a big opponent of the new direction the FDA seems to be going. So the FDA was drifting away from approving products based on surrogate endpoints and forcing the process to be more attentive to patient-reported outcomes and life expectancy. And she pointed out that among 54 new cancer drugs that were approved, 36 of them were approved on the basis of surrogate markers in a recent go-around. And that if you look at these drugs that were approved based on surrogate markers, it turns out that in 31 of the 36, there was no evidence that they improved life expectancy. And in 15 of 18 of them, there's no evidence that they improved quality of life. And actually, one drug that doesn't increase life expectancy and doesn't improve quality of life was approved, and it's on the market for $170,000 per year per patient. Again, having ripple effects through the health insurance premiums we all pay. So I think I'll just skip this because it will come up in the discussion. So part of what I've been arguing is we do the things we do because it fits a narrative. And this narrative has been around since Vinegar Bush and others, maybe back to Newton. It's a mechanistic narrative. And I hope I've persuaded you that it just doesn't work that well. And I'd like to just raise the question of, well, what is it that we're not doing because it doesn't fit the narrative? And so here's just one example. I had the opportunity to work with George Howard at University of Birmingham in Alabama, who has this prospective cohort for a big stroke study in epidemiology, where he's following about 33,000 people. And I just asked him if we could look at the relationship between educational attainment and life expectancy. And so the red bars are people who've completed college, and there's some college, yellow, high school graduation, blue, and then less than high school is black. And this is the probability of death within the 7 years that we followed them. There's just a huge relationship. And if you adjust for demographic variables, it's still there, although it's attenuated. If you adjust for income, add that to the model in addition to the others, still there. If you adjust for every imaginable biologic variable, which is in his database, still doesn't go away. And if you adjust for behavioral variables on top of that, it still doesn't go away. It attenuates, but it's still there. You can't get rid of it. So is this a big effect? And it's good we have a member of the U.S. Preventive Services Task Force. I mean, he's one of the groups I admire most. But the task force years ago debated forever about whether or not pap smears should be given every year or every third year. And this is a huge thing and big meta-analyses. Turns out that the increment in life expectancy, if you get a pap smear every year versus every third year, it could be a day in some analyses, but the analysis I looked at said about 8 hours, and that's the best case. Mammography, for all ages, it could be a month. A lot of people say nothing, but it could be a month, but not much more than that. Using data that we got from the Whitehall study, this is before people were treated. So systolic blood pressure, if you have systolic blood pressures in the 140 to 160 range and you get it down to the 120 to 130 range, it'll give you about 6 months of life expectancy. I'm sorry, there's LDL cholesterol. I have that reversed. Blood pressure is a little bit better. It's over a year. Smoking is about 6 years. Doesn't quite fit the narrative. Actually, the difference between having less than a high school education and having a graduate degree is about 12 years. I mean, it's enormously different. Now, if we go back to our family of four and look at the education study, the argument I'd like to make is, look, education has a profound effect, although they're not randomized clinical trials. It doesn't fit the narrative. By the way, when we published the study, it was turned down by a couple journals. Two of the reviewers from the first journal said, well, this seems to be an interesting effect, but what's the mechanism? So it doesn't fit this mechanistic model. But if you think about this, if this family of four has an income of $50,000 per year, and now $25,000 is being paid on their behalf from various sources, this is not all from the income, but it's still being paid. If that money was set aside, or a big part of it was set aside for a college fund for these two kids, at $50,000 a year, they're not putting much aside for college. But in fact, we're eating up, we're foreclosing the opportunity to spend more on other things. The last point I want to make is that if you look at how we spend money on healthcare, we make the assumption that context is unimportant. I shouldn't say, we don't really make that assumption, but I want to, for the sake of argument, context, as we've been discussing today, is hugely important. But we don't look at it that way. It turns out that if we look at our $3.2 trillion expenditure on healthcare, that about 22% of it is spent on 1% of the population, and about 50% of it is spent on 5% of the population. And so 50% of 3.2 trillion is a lot of money. It's 1.6 trillion. It's about the same as the GDP of Italy. And that's what we spend on about 5% of our population. And if we look at where this is coming from in relation to the topics we've discussed today, it turns out that there's a huge synergy between mental health and substance abuse and expenditures on healthcare. So the biggest group in that 5% are people who actually have comorbid substance abuse and mental health problems. So you've seen this slide too many times, I know, so I'll skip that. And let me just sort of get to the end. I do want to say that the NIH, when I was there, says they spend about 10 to 15% of their budget on behavioral and social sciences research. It's actually not true, and there's a methodologic problem because they count every grant multiple times. So each NIH grant in the RCDC system is coded 6 times. And so when I was at NIH, we actually hired a consulting firm to come in and look at how much are we really spending on behavioral and social sciences research. And it turns out that instead of 3.4 billion, it's actually about 600 million. So it's still a lot of money, but nowhere near what it's advertised to be. So how do I conclude all this, since I've talked longer than I should have? So the first point I wanted to make is, look, the US does lead the world in some things. You know, we're doing really well. We spend more than anybody else. And we spend more than anybody else on biomedical research. And as all the people that came to see me when I was at the NIH argued, we're doing really great. We ought to just keep doing exactly the same thing. But we're not leading the world in health outcomes. In fact, we've been losing ground for the last 50 years, and steadily. And the model that's based on mechanisms has resulted in my opinion, by the way, there's some great things that have come out of the mechanistic model. I sort of overstated it to make the argument. But in fact, it fails to recognize biologic complexity. It fails to recognize social complexity. In fact, the argument among mechanists is that everything happens quite independently. The parts are disconnected. And so we just need a new science that attends both to social complexity and biologic complexity. And more importantly, maybe it's time to rethink the way we allocate resources. We're certainly going to do basic science research. We don't want to give that up. It's too important. But among this budget that the NIH institutes have, shouldn't we think a little bit more about complexity, community health sciences, how we allocate them in the interest of improving population health? So, to quote Albert Einstein, insanity is doing the same thing over and over again and expecting different results. So Richard, I think I said I would talk less than the time, but I ran over a little bit. So anyway, if I have time for a question, I'll take it. Okay. Yeah.
Hi. My name's Alan Balsam, and I think you're probably about my age based on your hair color. You get a PSA?
I don't. And
What would you tell your brother if he asked you that?
my brother did ask me that.
My brother just asked me that question.
Yeah. My brother's older than I am, and so that, you know, I think that the probability of harm exceeds the probability of benefit, and that the types of harm are things that he worries about. You know, the PSA thing is coming back now, so there's just a new paper that came out last week from Ruth Etsunami and the group at the Hutch. And that, so, you know, basically, and I don't know where the task force redoing it.
Well, the draft statement came out.
Oh, the draft statement came out, of course, yeah. So you're tending back toward, you know, there's equivocating. And Ruth's paper looked at the two big trials, PLCO trial and then there's the European trial. They found a way to reweight some of the European data and say that it goes from no benefit to a tiny, tiny benefit. What did you do?
I said I don't want to be the one guy who didn't get his PSA and dropped dead of prostate.
Yeah.
I mean, I know for populations what the data says, but when it's somebody you care about and they're that one person, that's what I said. I don't know.
Yeah,
I don't know.
but then the probability, so there is real genuine probability of harm. And with all the cancer screening tests, and that's really a complicated question. So, I mean, interestingly, my doctor, and I did it, said, you know, okay, it's time for your colonoscopy, you know, go do it. And so I looked at the evidence, and the task force did it last 2 years ago, I guess. So, you know, from my particular set of circumstances, I reduced my probability of death from colorectal cancer from maybe 2.7% to 2%, so 0.7%. But I think in that example I gave of the woman, I think that what most people think is, I'm never going to die of colon and rectal cancer because I got a colonoscopy, where in fact you change your probability and only very slightly. And you know, when I talk to clinicians, clinicians know this. I mean, it's not a secret to them, but I think what they may be thinking is, if I really promote this, I'm doing good because I'm going to save a life collectively for the panel of people I serve.
Thank you.
Yeah. Yeah.
You said it in your talk. You said the challenge with epidemiological studies is it's not mechanistic. But yet, we're standing at the verge of analysis, big data analysis, of actually managing to deal with complexity. But the challenge is that it's not mechanistic. And how do we convince whoever it is that needs to be convinced that the data there is valuable? And I think specifically of virtual clinical trials, the Acorn study was predicted by Kaiser Permanente analysis of its database of 6 million people. And when they showed that retrospectively that getting the sugar level down to quote unquote normal for non-diabetics actually increased mortality, they actually stopped the Acorn study early because they started to see the same thing. So we actually have the ability now through big data and epidemiological studies, but again, it's back to your mechanistic. It doesn't define cause. It doesn't define mechanism, but that's the way to look at complex problems.
So there's going to be a whole evolution, I think, in these new methodologies using big data and alternatives to randomized clinical trials, including getting at the efficacy effectiveness problem. And we are actually working on this problem now. So part of the difficulty has always been that modelers have gotten it wrong when they knew the results of the trial. So for a great example is the Women's Health Initiative clinical trial, where modelers said, stupid to do the trial, we already know that Prem-Pro is great and every woman should take it. And then the trial came out in the opposite direction, and then they did the modeling over again, and they said, oh yeah, well, we could have told you it was going to be negative. So if you know what the results of the trial are going to be, then it's dangerous to do the modeling. On the other hand, with clinicaltrials.gov, the key thing I didn't mention about what's the difference between the trials published before 1970 and those after, I forgot to mention. The key variable is that in 1997, the Food and Drug Administration required registration of trials prospectively in clinicaltrials.gov, where you had to say prospectively what your primary outcome was. And that's when things really changed. And NHLBI started, so by 2000, they had all their trials requiring that. And as soon as they did, the number of positive trials just kind of fell off the cliff. So anyway, with clinicaltrials.gov, you know what trials are in play, you can model them, and then you can estimate that. And I think this is going to be a really big new direction. I'll just, one other comment, because I can't resist it, on mechanism. When I was at NIH, the NIH Common Fund wanted to do something on physical activity. And the argument was that, there's just overwhelming evidence that, I think overwhelming evidence that physical activity is good for you. And that it's related to life expectancy, it's related to functional outcomes and all kinds of stuff. And so they wanted to do some stuff that was more community science oriented, more dissemination oriented. And colleagues came in and they said, we can't advise people to exercise because we don't know what the mechanism is. And so what we have to do is we have to first have the Commons Fund spend $500 million or something figuring out what the mechanism is. I mean, it'd be like saying, we can't tell people to stop smoking because we don't know what the mechanism is. And so we have to wait till we identify the exact mechanism. I think that's nonsense. All right, I'll get out of the way. Thanks.
So it's lunchtime, but we will be back at 12:45. That's about 25 minutes from now. 12:45 for the next panel on violence. Thank you.